associated, right? Gynecomastia is a breast enlargement in male due to increased estrogen, okay? Increased estrogen compared to androgen activity. It's physiology in newborns. So every newborn has some sort of gynecomastia, but then it gets better. If it says persist after puberty, that's the idea, okay? Now it can cause by liver cirrhosis, hypogonadism. We talked about Klinefelter yesterday, but mostly drugs, okay? Drug-induced gynecomastia like a spironolactone, cimetidine, ketoconazole, those three drugs you cannot forget, folks, okay? So those are caused drug-induced gynecomastia. And that's that, folks, okay? Now, next, inflammatory process. Fat necrosis. If you remember from the day one, we talked about fat necrosis happens. There are two tissues. Most commonly happens when there is in the pancreas, right? When the pancreas has lipase, it causes all those things. But we also studied at that time, in the breast also you could have a fat necrosis, but it's non-enzymatic. Do you remember that? There is no enzyme. Okay, so that's the same thing, folks. It's always due to injury. We were talking about the trauma at that time. Okay, it's always due to that. So we find that on a mammography, necrotic fat and on a biopsy. Up to 50% of the patient may not even report trauma. They won't even remember that something happened. Just fat necrosis. I would highlight lactational mastitis. It happens during breastfeeding. Okay, when they breastfeed, the newborns, they bite and they crack the skin, so some organism can get in, increased risk of bacterial infection through the cracks. Staph aureus is the most common pathogen. One thing you need to know for step one, you could take antibiotic and still continue breastfeeding through the same site. Is everybody clear, folks? That's the only thing you want to remember, folks, okay? Continue breastfeeding. Now that brings you to your question. So what are the absolute contraindications for not breastfeeding? Those are active lesion, folks, HIV and active hepatitis, okay? Other than that, you are pretty much can breastfeed, okay? Now, benign tumors. Let's talk about this fibroadenoma. Now that it is most common in females, okay? And it's a mobile mass. You know, we studied a little bit this. Anytime a mass is movable, that can move mobile, it's benign. Anytime a mass is like a stony appearance, it doesn't want to move or thing, that's malignant. That's you want to worry more here, okay? This is a tumor composed of fibrous tissue and gland, increasing size and tenderness with estrogen. So that's prior to menstruation. So sometimes they give you this question, they ask you, what is the next best step? The answer is you ask the patient to come back once the patient is done with the menstrual cycle, because then it will change. If they come after the menstrual cycle, still it's there, then you will continue for further testing. Is that clear, folks? So that's the idea for that, folks. Okay, that's fibroadenoma. Now, these two, just to know the terminology, intraductal papilloma, which is a small fibroepithelial tumor within the lactoferous duct. Okay, that's all I would remember. There's nothing else to learn there. Phyllodes tumor is a large mass of connective tissue and cyst lobulation, most common in 5th decades, and some it can become malignant, but other than that, not important, folks. Okay, that's that. Next, fibrocystic changes. When you see a fibrocystic changes, most common in premenopausal female, 20 to 50, presence with premenstrual breast pain or lumps, often bilateral. Non-proliferative lesions can be there. Could be fluid-filled duct dilation and stuff, folks. Risk of cancer is usually not increased, okay? There are two types, sclerosing adenosis and epithelial hyperplasia. Sclerosing, it's all about calcification. That's the word, sclerosing, calcification, increased risk of cancer. And other one, epithelial hyperplasia, is a terminal duct and lobule epithelium, and that's also increased risk. Now, if you ask me, whatever I mark, if you know that, you shouldn't have a problem, anything, folks, okay? Because, you know, they probably want to ask you 1 or 2 questions that should be in gynecomastia. and lactational mastitis, folks. Okay, so that's important for this. Now let's go to the next section. These are actual malignant breast cancer. See, this we want to pay attention. We divide that into two, non-invasive and invasive. So we wanted to start here, folks. Okay, if you see non-invasive, the word of in situ. What did we say about in situ on the first day? Whenever it did not break the basement membrane, it means in situ, right? It has not spread. Okay, now look at the first one, ductal carcinoma in situ. So that happens in the duct. It fills ductal lumen. Okay, it comes from ductal atypia, often seen as early microcalcification on mammography. So some people are lucky, they will just find this on mammography and they could treat. If they didn't find out, let's say it goes, I want you guys to connect this. It become invasive ductal carcinoma. So that means it's now spreading. Okay, it has gone through the basement membrane and it's spreading. Same thing, folks. Firm, fibrous, rock hard mass. See, there's a difference between mobile mass versus a strong mass here, folks. With sharp margins and glands, folks, that's the idea. It's the most common type of invasive breast cancer. Okay, it's all about identifying. If you identify at a very early age, these patients can go easily through surgery and they could be cured. So that's ductal carcinoma in situ, how it becomes invasive ductal. Next, Paget's disease. This is important. Now, first thing to learn, take a look at the picture D here. That's Paget's disease, folks. Okay, so Paget's disease is an external skin manifestation. Is everybody clear, folks? So whenever you see this, patient has two things. One is this in the skin, and also it's a sign of underlying malignancy. So people with Paget's disease, there's an internal issue and an external issue. Is everybody clear? Two things are happening. Now read this. It's an extension of underlying ductal carcinoma in situ, invasive breast cancer, all the way to lactoferous duct, right? So what is Paget's disease? That's basically a severe version of eczema. That's a severe version of eczema, folks, okay? Now, seeing that eczema is not the worrisome, that's easy to treat. Underlying cancer is the one that need to be diagnosed. So that's Paget's disease. Is everybody clear? Okay, now next one, lobular carcinoma in situ. So that means it happens in the lobes, folks, okay? So this is a genetical decreased EEC adherent expression. So no mass or anything. It's an incidental finding, folks, okay? Incidental biopsy finding. So the lobular carcinoma can progress and become invasive lobular carcinoma. So that means now they are spreading. Look at the pathology. It's exactly the same, folks. What's the difference? One is breaking the basement, the other one is not. Okay, that's the only difference. So these are most common ones. Now look at the next one, medullary. It's a large anaplastic cells growing in sheets with associated lymphocytes and plasma cells. So we call it medullary, okay? Now I want to highlight the next one, inflammatory breast cancer. Now let's talk about a little bit of anatomy here, folks, okay? Now, so let's say this is the chest wall muscle, pectoralis major and stuff, and we have a breast tissue. We want to learn some anatomy here. Breast tissue is full of fat, okay? Of course, you have a fat tissue here, folks, that's understandable, but there is a ligament that gives you structural support. These are these ligaments, okay? Let me change the color. These are the ligament. These are called suspensory ligaments, okay? Suspensory ligament means it gives you the structural support to the breast tissue. Another name is called Cooper's ligaments, folks. I'm sure you heard that word, Cooper's ligament or suspensory ligament, right? Now, this is the skin outside, okay? This is a skin outside. Now, sometime what happens, folks, a malignant cancer is happening in the breast tissue. Watch what happens. These malignant cancers are infiltrating these ligaments. So you guys see that? When they infiltrate, what's going to happen? They're going to retract the skin. They're going to pull the skin inside. Is that clear, folks? When the ligament retract, they're going to start seeing little dimple on the skin. Is everybody clear, folks? When they see a dimple, look at this picture, F. Did you see this area? Those tiny, tiny dimple. These are all the Cooper's ligament is pulling inside. And they say, this looks like a skin of the orange, isn't it, folks? So even the nipple inverted, that means the ligament is inside is retracted. That's basically your inflammatory cancer, folks, okay? Now you could see here, it's a dermal lymphatic space invasion, breast pain with movements of skin around exaggerated hair follicle. Pure orange, basically it's involving. So you want to write it down somewhere, suspensory ligament infiltration or Cooper's ligament infiltration. That's what that gives a skin of the orange appearance. Is everybody clear, folks? That's why sometimes they teach you in pathologies that the minute you see an inverted nipple, it's always cancer, because that means something is pulling inside and there is no other than cancer to retract. Are we clear, folks? Can people die of breast cancer? Absolutely. Okay, absolutely. I literally know a person who had this. I put A and B. I know two patients. One, they had A, they found it early, simple surgery, they are alive. I also know the person that was little behind and got this disease and died. Okay, it's all literally timing, folks. Okay, so that's the idea here. These are breast cancers. Any question on breast cancer so far? All right. So some common information, folks. Okay. Now here it says commonly postmenopausal, often present as a palpable hard mass, often seen in upper outer quadrant. Invasive cancer can become fixed to pectoral muscle, deep fascia, Cooper's ligament. Look at that. So that's what we were talking about now. Okay. It comes usually from terminal duct, amplification or overexpression of estrogen progesterone receptor. These are estrogen receptor positive people. And those are the idea here. These are the basics, and that's breast cancer. They don't go too deep into it. They just want you to know the basics, because this is oncology, guys. Okay, it's a subspecialty. So that's breast cancers. All right. Now that take care of all the female parts. Now let's get into some male diseases. Now let's go for testicular torsion. We see it in youngsters, especially when they jump on the trampoline or some activities they do and they come, these kids, right? Now, rotation of the testicle around the spermatic cord, commonly presents in male between 12 to 18 years old, associated with sometimes the congenital inadequate fixation, folks. We'll see what is happening. Now, they come with extreme pain because when the testicular torsion happened, the blood vessel is also discontinued, right? Like compressed. So ischemic pain and stuff, folks, okay? Now, when they come, acute severe pain, high riding testis, and absent cremasteric reflex, and negative French sign, folks. We have to do surgical correction within 6 hours, orchiopexy. Remember, orchiectomy is different, orchiopexy is different. Pexy means we are repairing. Ectomy means removing. Is everybody clear, folks? So here we are not removing, we are repairing, okay? You have 6 hours. If not, then we have to remove it, because after 6 hours it dies. So it's orchiectomy. Usually what happens when they come to the ER, this ER physician, they try to unwind it. So what they do, when a patient comes with testicular torsion, we don't know which side it's torn, right? So which side is that? So how do we find out? We will try to move one side, and if they scream, then we know we are making it worse, then we will go to the opposite side, okay? That's how we try to do that, folks. That's called manual distortion of cell, right? So until you do that. So that's the idea. And then when the orchiopexy is performed, it should be bilateral because the contralateral testis is at risk, okay? Now there's a structure sometime, and they might possibly ask, let's say this is a scrotum and the testis is there, and there's a structure here I'm just drawing. This testis need to be anchored to that structure. This structure is called gubernaculum, okay, gubernaculum. Gubernaculum is a structure that holds the testis in position. So when we do the surgery, they actually stitch it together. Is that clear, folks? So that's the idea. Okay, so you want to know that. So when we do it in one side, we also do it on the other side. So in the future, they won't have a problem with that. Now, next, this is a high yield varicocele. Now, let's talk about this a little bit, folks, okay? Now, let's say I'm drawing the inferior vena cava. Okay. And we have this side, okay? And I'm just drawing both side testicle. We say this goes here, this is going here, okay? This is going here, folks, okay? Now, this testicular vein is almost like a network. Testicular veins is like a network here. We call this pampiniformis plexus, pampiniformis plexus. There's a name for it, it should be there. You see, pampiniform plexus, okay? That's a normal anatomical name for these veins. Now, if you see here, folks, venous blood is going this way. Is everybody clear? I want you guys to follow me. Don't write anything, watch this. This is important. Why do you think that testicles in male went down below the abdominal cavity during embryology? It's because testicle requires less temperature than your body temperature. Is everybody clear, folks? That's why it descended to the scrotum. So the scrotum has different temperature than your body. Okay, that's fine. But venous blood is going this way. Arterial blood, so let's assume you have aorta, right? Aorta is somewhere here. It has testicular artery. Testicular artery is going like this. Isn't it arterial blood is going this way? Don't you think so? Think carefully. If arterial blood is going from abdomen to the testicle, don't you think they're taking the same abdominal temperature to the testicle? Yes or no, folks? Because why? The whole idea of descending testicle is to maintain a different lower temperature. But if this arterial blood is going to go to the testicle, that means they're carrying the same abdominal temperature to the testicle. Isn't it, folks? That's wrong. So that's why we are created with this pampiniformis plexus. What pampiniformis plexus is, it goes around the artery and reabsorb all the heat. They reabsorb all the heat, so all the heat can go this way. Is that clear, folks? So pampiniform plexus is like a cooling mechanism for testicular artery. Is everybody clear, folks? Because remember, once the heat is gone to the vein, because the venous blood is going to the abdomen anyway, so it doesn't matter. Isn't it, folks? All right. So if anybody asks you what's a function of pampiniform plexus, now you know it. Okay. So that's the function, folks. Any question? No. Now what's going to happen, folks? Patient has some disease, renal cell carcinoma, anything that happens, it can come and block this area. Now, can the pampiniform plexus drain properly? No. So they're going to back up. They're going to back up. All those plexus is going to dilate. Right? What is plexus? These are small network, isn't it, folks? So they're going to dilate because of the blood backup. Now, when the patient comes, we're going to palpate in the physical exam. I'm going to feel like a bag of worms in my hand because those bag of worms are the pampiniform plexus, dilated pampiniform plexus. Is that clear, folks? All right. Now look at this. These are dilated vein in pampiniform plexus due to increased venous pressure. Most common cause of scrotal enlargement in adult males. Most often is left side because we know the left side has a resistance from the renal vein, folks. Right-sided varicocele may indicate IVC obstruction. See, look at this picture. For you to get the same problem on the right side, you have to have an IVC problem, isn't it, folks? All right. Can cause infertility. Now remember, if there is a renal cell carcinoma, the pampiniform plexus is not draining, can they take the heat? They cannot, even though they're absorbing the heat, but they cannot flow this way. So that means high temperature blood is going to the testis. That makes it infertile. Is that clear, folks? You see, that's why you need to know that. Normal function, folks. So people with varicocele need to be repaired ASAP. The longer they wait, there is a high chance to become infertile. Is everybody clear, folks? All right. Diagnosed by standing clinical exam, Valsalva, anything, folks? We see the bag of worms, the gravity will bring it. Okay. And then next, there's about something called the light, right? It does not translaminate because why, folks? If I put a light through that, it's a blood. The light cannot penetrate the blood. It will penetrate the water, but not the blood. Is everybody clear, folks? So that does not go through translamination, folks, okay? Treatment, consider surgical ligation or embolization, okay? So that's the idea. So that's varicocele. Are we clear? So we learned the normal function and the importance and the pathology. Now, what is closer to varicocele? The answer is hydrocele. Okay, that's hydrocele. Hydrocele can be congenital or acquired. What is hydrocele we talked about? Where did we talk about this? Come on, folks. Talk to me, talk to me. Where did we talk about hydrocele before? There was another disease we were talking, I mentioned. It's where indirect inguinal hernia. Indirect inguinal hernia, right? What did we say? What's the main pathology for indirect inguinal hernia? The process vaginalis did not close properly. And we said when they don't close, if you have a mass, that's hernia. Instead of a mass, if you have a clear fluid, that's hydrocele. Is that clear, folks? Now, if it is a clear fluid, the light will go through it. Is that clear? So that's the idea, folks, okay? Clear fluid will go through it. So that's that part. So everybody clear, folks? All right. So that's here. Now, let's go to this page. The whole page 6, 7, 8 is super high yield. Yeah. We need to do some anatomy, otherwise we cannot understand.